Hi, y'all. Welcome back to part two of lecture number 8. This slide is one of the most important take-home messages of this entire section, I believe. When it comes to atherosclerosis, the best treatment is prevention. Once plaque forms, we can manage it, but we cannot truly reverse the disease process in a clean, simple way. So everything we've talked about up to this point points kind of directly to this slide. So first, let's talk about lifestyle factors. Not in a judgmental way, but in a mechanism-based way. Stop smoking. Smoking directly damages endothelial cells and accelerates plaque formation. So this isn't just a risk factor, it's a direct contributor to injury. Lose weight. Excess adipose tissue promotes inflammation, dyslipidemia, and insulin resistance, all of which feed atherosclerosis. Reduce animal and saturated fats. So these fats increase LDL cholesterol, which is the lipid most likely to deposit in the arterial wall. Increase healthy plant and fish oils. These improve lipid profiles and reduce inflammatory signaling. Control blood pressure by reducing salt. Hypertension causes repeated mechanical stress on the endothelium, making it easier for lipids to enter and plaques to grow. Exercise regularly. Exercise improves lipid metabolism, blood pressure, glucose control, and endothelial health all at one time. From a pathology standpoint, prevention is really about protecting the endothelium. Then next we'll focus on some targeted medical management. So let's look at LDL cholesterol levels. The goal is to lower LDL to less than 100 milligrams. This can be achieved through dietary changes. So statins, which reduce cholesterol synthesis and stabilize plaques. Statins just don't lower cholesterol. They also reduce inflammation within plaques, making them less likely to rupture. If lifestyle and medical management fail, or if disease is already advanced, surgical intervention may be necessary. These procedures can't cure atherosclerosis, but they can restore blood flow and prevent catastrophic outcomes. Some examples include an endarterectomy, which is surgical removal of the plaque, angioplasty with stenting, so mechanically opening up those narrowed vessels, bypass grafts, rerouting blood around blocked arteries. These are structural solutions to a biological problem, and they work best when combined with continued risk factor management. So a big picture takeaway is that atherosclerosis is preventable. It is manageable, but it's not easily undone. So understanding the pathology helps explain why prevention works and why ignoring risk factors allows disease to progress silently for years. This slide puts hypertension into concrete numbers, and it's one you absolutely need to be comfortable with, both clinically and conceptually. Blood pressure isn't just a vital sign we record and move on from. In the context of atherosclerosis, blood pressure is a direct driver of endothelial injury. So let's walk through this table. Is systolic of less than 120 and diastolic of less than 80. This is where the endothelium is under the least mechanical stress. Normal pressure helps preserve vessel integrity and slows atherosclerotic progression. An elevated blood pressure can be anywhere from systolic 120 to 129 and diastolic still less than 80. This category matters more than people realize. There's no hypertension diagnosis yet, but the vessel wall is already being exposed to increased shear stress. From a pathology standpoint, this is where early endothelial dysfunction can begin, even without symptoms. So we have hypertension stage 1. This is a systolic of 130 to 139 or diastolic of 80 to 89. At this point, we're no longer just talking about risk, we're talking about ongoing vascular injury. Sustained pressure in this range disrupts endothelial cell junctions and makes it easier for LDL to enter the intima. It also accelerates plaque formation. This is why stage 1 hypertension is such a strong contributor to atherosclerosis. Hypertension stage 2 That we have a systolic of greater than or equal to 140 or a diastolic of greater than or equal to 90. Now we're in a range where damage is cumulative and progressive. Chronic exposure to pressures this high thickens vessel walls, promotes smooth muscle proliferation, and increases plaque instability. This is where complications like coronary artery disease, stroke, and aneurysm formation become much more likely. A hypertensive crisis, this is where we'd see a systolic pressure of greater than 180 and or diastolic greater than 120. And folks, this is a medical emergency. At these pressures, vessels can't compensate. Endothelial cells can shear, plaques may rupture, and small vessels may hemorrhage. From a pathology perspective, this is acute injury layered on top of chronic disease. So just remember, hypertension isn't just a number, it's repeated mechanical trauma to blood vessels. Every category above normal increases endothelial injury, lipid infiltration, plaque growth, and the risk of thrombosis. That's why blood pressure control shows up repeatedly in atherosclerosis prevention. It directly protects the vessel wall. This slide highlights one of the most important and most frustrating features of hypertensive disease. It's usually asymptomatic. Hypertension is often called the silent disease. Most individuals have no obvious symptoms even when blood pressure has been elevated for years. That means no pain, no warning signs, no clear something is wrong feeling. By the time symptoms appear, vascular damage is often already well established. Because hypertension is typically asymptomatic, it's often most identified through routine blood checks, preventative health screenings, or clinic visits for unrelated issues. This is why regular screening is so critical. Without measuring blood pressure, hypertension can progress unnoticed while continuously injuring blood vessels. One of the few places we can directly visualize vascular damage from hypertension is the eye. On ophthalmoscopic exam, retinal vessels may show thickening, arterioles may appear narrowed, advanced cases may show hemorrhages or papilledema. This matters because the retina provides a window into systemic vascular health. What we see here often reflects what's happening throughout the body, in the brain, the heart, the kidneys, and the peripheral vessels. Even without symptoms, sustained high blood pressure damages those endothelial cells. It promotes arterial sclerosis and atherosclerosis. It increases risk for stroke, myocardial infarction, and kidney disease. So the absence of symptoms does not mean absence of disease. And hypertension doesn't announce itself, but it does leave evidence. So if you remember nothing else, remember this. Hypertensive disease causes chronic vascular injury long before patients feel anything is wrong. That's why screening, early identification, and prevention are so central to managing vascular disease. Now let's talk about blood pressure and what it really actually is and how we measure it in a clinical setting. Blood pressure is measured using a sphygmomanometer, which is a fancy word for an inflatable cuff attached to a pressure gauge, used together with a stethoscope. The cuff is typically placed around the upper arm over the brachial artery. When the cuff is inflated, pressure in the cuff increases. The artery underneath becomes compressed. When cuff pressure is higher than systolic pressure, blood flow stops completely, and so no sound is heard. As the cuff slowly deflates, blood begins to flow again, but not smoothly at first. Korthoff sounds. These are the sounds you hear through the stethoscope, and they happen because blood flow becomes turbulent as it squeezes through a partially compressed artery. Here's how to interpret them. The first appearance of sound marks the systolic pressure. Sounds continue as the arteries opens more with each heartbeat. The disappearance of the sound, this marks the diastolic pressure. Once cuff pressure drops below diastolic pressure, blood flow becomes smooth again and the sounds stop. The graph helps visualize what's happening. The red wave represents arterial pressure. The green line shows cuff pressure decreasing over time. Where the green line crosses the peaks of the red wave is the systolic. Where the green line drops below the red wave entirely is diastolic. This visual reinforces that blood pressure is dynamic, not static. Accurate blood pressure measurement is essential because hypertension is often asymptomatic, like we said, and small measurement errors can lead to misclassification. Chronic elevation contributes directly to vascular damage, atherosclerosis, and organ injury. So again, just remember, blood pressure isn't just a number. It's a reflection of arterial health, cardiac output, and vascular resistance. Understanding how it's measured helps explain why it matters so much in vascular disease. Now we're shifting from atherosclerosis into another major inflammatory and degenerative vascular disease, hypertension. At its simplest level, hypertension just means high blood pressure, but the why behind that elevation matters. Remember this relationship shown on the diagram. Blood pressure equals cardiac output times peripheral resistance. So blood pressure can increase if the heart pumps more blood, or the blood vessels offer more resistance, or both are happening at the same time. Most causes of hypertension involve changes in peripheral resistance, not just the heart. Essential hypertension is the most common form of hypertension, and it's considered primary or idiopathic, meaning there is no single identifiable cause. Instead, it results from a combination of factors. These factors often include genetics, diet, especially sodium intake, obesity, chronic stress, and altered vascular tone. And even though there's no single cause, the end result is persistent elevation of blood pressure, which leads to long-term vascular damage. Secondary hypertension is different because it is the result of another identifiable condition. If the underlying problem is treated, blood pressure may improve or normalize. Common causes include renal disease, endocrine disorders like hyperaldosteronism, certain medications, and vascular abnormalities. This distinction is important clinically because secondary hypertension may be reversible, whereas essential hypertension usually requires lifelong management. The diagram highlights how multiple systems regulate blood pressure. So a blood volume, we have the sodium balance and hormones like aldosterone and ANP. Cardiac factors are heart rate and contractility. Peripheral resistance are controlled by neural factors, so our sympathetic tone. Humoral factors are angiotensin II, NO, or the prostaglandins. Local autoregulation. And then hypertension develops when these regulatory systems shift towards chronic vasoconstriction, increased volume, or both. Why this matters pathologically is that chronic hypertension damages the endothelium. It accelerates atherosclerosis, which leads to thickened, stiffened vessels. And that increases risk for heart disease, stroke, kidney failure, and even vision loss. So even though hypertension often starts silently, its long-term consequences are anything but subtle. And also remember again, hypertension is not just a number on a cuff. It's a chronic vascular disease driven by complex interactions between the heart, the blood vessels, the kidneys, and hormones. Understanding whether it's essential or secondary shapes both diagnosis and treatment. So up to this point, we've talked about blood pressure almost like a number on a screen. Now we're going to talk about what chronic changes in blood pressure actually do to blood vessels over time. So structurally, histologically, and functionally. Let's start with the big picture. Your body works very hard to maintain blood pressure within a normal range. That's what we mean by homeostatic mechanisms. The heart, kidneys, blood vessels, and nervous system are constantly adjusting things like vessel diameter, blood volume, and cardiac output to keep tissues perfused. Think of blood vessels like flexible garden hoses. When pressure is normal, the hose expands and recoils appropriately. When pressure drops too low, which is hypotension, there simply isn't enough force pushing blood into the tissues. That's when you start seeing poor perfusion, which can lead to organ dysfunction and, in severe cases, tissue necrosis. Cells can't survive without oxygen and nutrients for very long. Now, flip that scenario. With chronic high pressure or hypertension, vessels are being hit with constant mechanical stress. This is not a one-time injury. This is wear and tear over years. The endothelium, which is supposed to be smooth and protective, starts to get damaged, And once the endothelium is injured, everything downstream starts to change. Here's where histology really matters. Blood vessels don't just sit there and take it, they remodel. The diagram on the right shows the different ways vessels adapt. Some vessels undergo hypertrophy, where the wall thickens. Others remodel inward or outward, changing the lumen size. Sometimes the wall thickens and the lumen narrows. From a histology perspective, this means increased smooth muscle mass, thickened intima and media, reduced lumen diameter, especially in small arteries and arterioles. So if you're cutting sections from a hypertensive patient, those vessels often look crowded and stiff, not nice and open. This matters because a narrowed lumen increases resistance, which further raises blood pressure. It's just a vicious cycle. A useful analogy here is lane reduction on a highway. If you go from 4 lanes to 2, traffic backs up. Blood flow works the same way. Narrower vessels equal higher resistance, which equals more pressure upstream. Over time, this remodeling evolves into vascular damage, contributing to things like ischemia, organ damage, especially kidney, brain, and heart, and increased risk of thrombosis. And here's a quick fun fact to tuck away. Small vessel changes from hypertension are often microscopic long before they're clinical, meaning histology can show damage well before symptoms show up. This is why hypertension is often called a silent disease. So when we talk about hypertensive vascular disease, we're really talking about structure, function, and time. And histology lets us see that damage long before it announces itself clinically. Now we're going to zoom in literally and talk about what hypertension does at the cellular level, starting with the endothelium. Hypertensive vascular disease almost always begins with endothelial injury, and that's a big deal because endothelial cells are not passive wallpaper lining blood vessels. They're metabolically active, highly responsive cells. Under normal conditions, endothelial cells carefully regulate what moves in and out of the vessel wall. They help control the movement of gases like oxygen, nutrients and metabolic wastes, and electrolytes and other solutes. They also play a major role in vasoconstriction and vasodilation, releasing substances that tell smooth muscle cells when to tighten and when to relax. So when hypertension causes repeated mechanical stress, that constant pounding of high pressure, endothelial cells start to malfunction. One of the earliest changes is increased leakiness, and this happens in both directions. Things that should stay in the blood leak into the vessel wall. Things that shouldn't escape the vessel now can. At the same time, injured endothelial cells begin producing abnormal signaling molecules, especially ones that affect smooth muscle cells in the vessel wall. This leads us to the hallmark histologic change you should absolutely remember: intimal thickening. Smooth muscle cells begin to proliferate and migrate from the media into the intima. And here's an important shift. These cells stop behaving like contractile muscle cells and start acting more like matrix-producing factories. In other words, they lose their ability to contract effectively and instead start synthesizing scar-like material, including collagen and elastin and other extracellular matrix substances. From a histology standpoint, this is why hypertensive vessels look thick-walled, stiff, and less compliant, and they often have a narrowed lumen. A helpful analogy here is comparing a healthy vessel to a stretchy rubber band, flexible and responsive. A hypertensive vessel is more like a duct-taped rubber band, thicker, stiffer, and not very good at adapting. And here's a histology fun fact to tuck away. Once smooth muscle cells switch to this synthetic phenotype, the process is very hard to reverse, even if blood pressure later improves. So when you're looking at vascular sections from a hypertensive patient, you're not just seeing thick walls, you're seeing the cellular memory of chronic injury. At this point, the obvious question is, if hypertension causes all this damage, where does it actually come from? In about 95% of hypertension cases, there is no single underlying disease or condition that we can point to as the cause. When that happens, we classify it as primary or essential hypertension. And yes, I know students hate that word essential because it sounds like it means important. In medicine, it really means we don't have one clear cause. Genetics play a significant role here. Hypertension tends to run in families, and certain ethnic groups are at higher risk. That doesn't mean it's inevitable, but it does mean the baseline risk is higher before lifestyle factors even enter the picture. A major player in blood pressure regulation, and one you should always keep in the back of your mind, is the kidney. There's a common saying in pathology and physiology: hypertension travels with the kidney. The kidneys are the long-term regulators of blood pressure. They control sodium balance, water retention, blood volume. So when kidney regulation is off, even slightly, blood pressure tends to follow. That brings us to dietary sodium. High sodium intake increases blood volume, which increases pressure on vessel walls. Reduced sodium intake has been shown to be one of the most effective non-pharmacological ways to lower blood pressure. If you want an analogy, think of your circulatory system like plumbing in a house. More salt is more water retained, which equals higher pressure in the pipes. Eventually, the pipes don't like that. Lifestyle factors also significantly contribute, especially when layered on top of genetic risks. So chronic stress, obesity, diabetes, smoking, and lack of regular exercise. Each of these factors either increases vascular resistance, blood volume, or endothelial injury, and often all three. So the key takeaway from this slide is that hypertension is not a single pathway disease. It's a complex disorder that results from an ongoing interaction between our genetic predisposition, our environmental factors, and our lifestyle choices. And from a histology standpoint, what matters most is that regardless of the cause, the vessel wall responds in very predictable and very damaging ways over time. So far, we've talked about primary hypertension, the common multifactorial kind. Now let's look at the smaller but very important group, secondary hypertension. Secondary hypertension accounts for about 5% of all hypertension cases, which makes it much less common but clinically very important because there is an identifiable cause. In most cases, secondary hypertension is linked to renal disease, which should not surprise you after the last slide. The kidneys are the long-term regulators of blood pressure, so when something interferes with renal blood flow or function, blood pressure often becomes a downstream problem. Some common renal causes include renal artery stenosis, where reduced blood flow tricks the kidneys into thinking systemic pressure is low. We have chronic renal failure, where damaged nephrons can no longer regulate sodium and fluid balance effectively. Then there's renal tumors, which may alter renin production or compress normal renal tissue. If you want a simple analogy, the kidney is the thermostat for blood pressure. If the thermostat is broken, the system keeps cranking the heat, even when the room is already overheating. Secondary hypertension can also be caused by excess steroid or catecholamine hormones, which directly increase vascular tone, blood volume, or cardiac output. Examples include Cushing syndrome, where excess cortisol enhances vasoconstriction and sodium retention, adrenocortical hyperplasia, so leading to overproduction of mineralocorticoids, adrenal medullary tumors such as pheochromocytomas, which flood the system with catecholamines. From a histology perspective, what's important to recognize is that the vessels don't care why the pressure is high. Whether hypertension is primary or secondary, chronic elevated pressure still produces endothelial injury, smooth muscle proliferation, and extracellular matrix deposition. The difference is that with secondary hypertension, treating the underlying cause can actually reverse or significantly improve the condition rather than just managing the pressure itself. So secondary hypertension is less common, but when you find it, it's one of the few times in pathology where fixing the source can actually stop the cascade. Okay. Now let's organize secondary hypertension in a way that actually makes sense clinically and pathologically. Secondary hypertension isn't random. It tends to fall into predictable categories based on the system that's disrupted. This slide is essentially a roadmap for where to look when blood pressure has a clear underlying cause. So renal causes are the most common contributors to secondary hypertension. Anything that damages kidney parenchyma interferes with the kidney's ability to regulate sodium, water, and renin release. So examples here would include chronic pyelonephritis or cystic disorders, which destroy normal nephron architecture, acute renal diseases such as acute glomerulonephritis, renal artery disease, most often due to atherosclerosis, which reduces perfusion pressure. Histologically, this often translates into glomerulosclerosis, interstitial fibrosis, and vascular narrowing, all of which reinforce hypertension rather than relieve it. Think of it this way. If the kidney can't see enough blood, it assumes the body is hypotensive and turns the pressure up. We have endocrine causes. So endocrine disorders cause hypertension by clinically altering vascular tone, blood volume, or cardiac output. These include increased adrenal hormone secretion, such as the catecholamines or the corticosteroids, exogenous steroids, which mimic endogenous hormone excess, thyroid dysfunction, both hyperthyroidism and hypothyroidism. From a tissue standpoint, chronic hormone exposure leads to persistent vasoconstriction, smooth muscle hypertrophy, and endothelial stress, setting the stage for long-term vascular damage. Neoplastic causes. Some tumors directly drive hypertension through hormone production. The classic example is a pheochromocytoma, which secretes catecholamines in bursts, producing episodic or sustained hypertension. Other tumors may produce hormones directly, compress vascular or renal structures, or disrupt normal feedback loops. These cases often stand out clinically because the hypertension can be severe, sudden, or very difficult to control. Then there's neurological causes. Neurological conditions influence blood pressure through central control mechanisms. These include increased intracranial pressure, which triggers systemic vasoconstriction, sleep apnea, where repeated hypoxia activates sympathetic pathways, and acute stress states such as surgery or trauma. Although these causes aren't primarily vascular, the endothelium still pays the price over time if elevated pressures persist. And lastly, cardiovascular causes. Finally, structural or hemodynamic cardiovascular abnormalities can raise pressure by altering flow or resistance. Examples include aortic rigidity or coarctation, which increases proximal pressure, arteriovenous fistulas, which increases cardiac output, expanded intravascular volume, such as in pregnancy, conditions with increased cardiac output like anemia, toxemia of pregnancy, where endothelial dysfunction plays a central role. Histologically, these conditions often produce adaptive and then maladaptive vascular remodeling, similar to what we see in chronic primary hypertension. But the big takeaway here is that secondary hypertension isn't mysterious, it's mechanistic. If you know which system is broken, the blood pressure makes sense. And this slide is where we talk about consequences. Chronic hypertension isn't just a number problem, it's a progressive, multi-organ injury process, and the damage shows up most clearly in the heart, brain, and kidneys. The cardiovascular system takes the first and hardest hit. Long-standing high blood pressure forces the heart to pump against increased resistance, leading to left ventricular hypertrophy, which eventually progresses to heart failure. Accelerated atherosclerosis, because injured endothelium is more permeable and pro-inflammatory. Myocardial infarction, often due to plaque rupture and thrombosis. Aneurysm formation, particularly in large elastic arteries. And then aortic dissection, where chronic pressure weakens the vessel wall until it literally splits. Histologically, this is where you see intimal thickening, smooth muscle hyperplasia, fibrosis, and then loss of elastic recoil. The vessel wall becomes less flexible, like a garden hose left out in the sun too long. Neurologic complications. In the brain, hypertension damages small penetrating arteries and arterioles, which are especially vulnerable. Major outcomes include a cerebrovascular accident, both ischemic and hemorrhagic. Cerebrovascular accident is also just referred to as a stroke. Intraparenchymal hemorrhage due to rupture of weakened vessels. Blindness, often from hypertensive retinopathy. And memory impairment related to chronic ischemic injury and microvascular disease. From a pathology perspective, chronic hypertension produces hyalinine arteriosclerosis in the brain, narrowing lumens and reducing perfusion over time. This is why hypertension is sometimes called a silent stroke risk. Damage accumulates quietly until it doesn't. Renal complications. The kidneys are both victims and accomplices in hypertension. Sustained high pressure causes chronic renal failure, which progression to end-stage kidney disease, eventual dialysis dependent. And then histologically, this correlates with glomerulosclerosis, tubular atrophy, interstitial fibrosis, and hyaline arteriosclerosis of the renal arterioles. Once enough nephrons are lost, the kidney can no longer regulate pressure effectively, creating a self-perpetuating cycle. The key takeaway is this. Hypertension doesn't fail organs randomly, it fails them predictably. Heart, brain, and kidney damage are not side effects. They are expected outcomes if hypertension remains uncontrolled. This is the hopeful slide, the one where we remind ourselves that hypertension is absolutely treatable. And like many degenerative diseases, hypertension responds very well to lifestyle modification and medication. When we reduce pressure, we reduce ongoing endothelial damage, and that matters at the tissue level. First, the non-pharmacological side, which is not optional even when drugs are used. General treatment strategies include weight loss, which decreases peripheral resistance, regular exercise, improving endothelial nitric oxide production and vascular compliance, smoking cessation, which directly reduces endothelial toxicity, reduction of excessive alcohol intake, and reduction of dietary sodium, which lowers our intravascular volume. A diet low in saturated fat, cholesterol, and total fat. From a histology standpoint, these interventions improve endothelial function, they reduce inflammatory signaling, they slow muscle contraction proliferation, and decrease extracellular matrix deposition. Think of this as taking pressure off a stressed vessel wall before it cracks. There's also drug therapy. When lifestyle changes aren't enough, and often they aren't, medications are added. Key pharmacologic treatments include thiazide-type diuretics, which are a mainstay. They reduce plasma volume and peripheral resistance. Blood pressure medications targeting vascular tone, cardiac output, and renal sodium handling. And then there's combination therapy, which is common. Multiple drugs are often required because hypertension isn't driven by a single mechanism. It's a systems problem, not a single faulty switch. Why this matters histologically is that lowering blood pressure can reduce ongoing endothelial damage, it can slow intimal thickening, and limit fibrosis and hyaline deposition. It also preserves organ perfusion. In other words, treatment doesn't just improve numbers, it preserves tissue architecture. Hypertension damages vessels slowly, but treating it slows that damage just as effectively. And that's the key takeaway for histotechnology. Pressure control is tissue preservation. Hypertension is slow, mechanical damage, then vasculitis is inflammation with an attitude. Vasculitis is a broad umbrella term used to describe a group of uncommon but serious diseases characterized by inflammation of blood vessels. And when we say blood vessels here, we are almost always talking about arteries. Vasculitis involves inflammatory destruction of vessel walls, narrowing, weakening, or complete occlusion of affected vessels, and compromised blood flow to downstream tissues. Unlike hypertension or atherosclerosis, this isn't gradual wear and tear. This is active, immune-mediated injury. Most forms of vasculitis are autoimmune in nature and driven by abnormal immune activation targeting vascular components. The immune system essentially mistakes the vessel wall for the enemy, and the result is inflammation, necrosis, and sometimes hemorrhage. At the microscopic level, vasculitis can show inflammatory infiltrates within vessel walls, so neutrophils, lymphocytes, macrophages. We could also see fibrinoid necrosis in severe cases and disruption of the tunica media and intima, as well as thrombosis secondary to endothelial injury. This explains why vasculitis is so dangerous. You're not just narrowing vessels, you're destroying them. Because blood vessels are everywhere, vasculitis can affect multiple organ systems simultaneously, including the brain, as in a stroke, the heart, as in myocardial infarction or hypertension, the lungs, hemorrhage and infiltrates, and kidneys, as in glomerulonephritis. The skin, we could have palpable purpura and livedo reticularis. The GI tract can result in abdominal pain and bloody stool. This multi-organ involvement is why vasculitis is often difficult to diagnose and potentially life-threatening. Vasculitis doesn't politely stay in one organ, it goes wherever blood flows. From a histotechnology standpoint, vessel biopsies are critical, proper fixation and orientation matter, identifying inflammatory patterns can be diagnostic. So a big picture comparison is hypertension is that mechanical stress, atherosclerosis is the lipid and inflammation, and then vasculitis is immune-driven vascular destruction. 3 vascular diseases, 3 very different mechanisms, very different histologic fingerprints. Okay, now that we've talked about vasculitis in general, let's put some real names and real faces to it. Okay, this slide highlights two classic examples of vasculitis, each with very different patterns of vessel involvement and histologic features, but both driven by immune-mediated vascular injury. The first one we have is systemic lupus erythematosus, or SLE. SLE is a chronic autoimmune disease that can affect multiple organs and systems, including the skin, kidneys, joints, heart, and blood vessels. Clinically, many patients develop the classic malar or butterfly rash across the cheeks and nose, which you can see in the image on this slide. But histologically, the real story is happening inside the vessels. Immune complexes deposit in vessel walls. This triggers inflammation and endothelial injury, results in vasculitis, especially in small vessels. In the kidney, this can progress to lupus nephritis, which is why renal biopsies are so common in SLE patients. As a histotech, you're often looking for immune complex mediated damage, so thickened vessel walls and inflammatory infiltrates, sometimes subtle and sometimes dramatic. The next one is the polyarteritis nodosa, or PAN. Polyarteritis nodosa is a vasculitis that primarily affects medium-sized arteries, not capillaries and not veins. It's characterized by segmental nodular inflammation, weakening of the vessel wall, and alternating areas of stenosis and aneurysmal dilation. The skin findings shown here are purpura nodules, ischemic changes, are a direct result of compromised arterial blood flow. Transmural inflammation of medium-sized arteries, we might see fibrinoid necrosis is common. Healing leads to fibrosis and luminal narrowing. Think of PAN like this. Imagine a garden hose that's been attacked by inflammation in patches. Some areas balloon out, others scar down. Blood flow becomes chaotic and unreliable. From a lab perspective, diagnosis often relies on vessel biopsies. Proper sectioning is critical. You want the vessel in cross-section. Missing the artery is missing the diagnosis. Special stains and immunofluorescence may be required depending on suspected etiology. So comparison here, SLE vasculitis is immune complex driven, systemic, and often small vessels. Polyarteritis nodosa is necrotizing inflammation of medium arteries. Different mechanisms, different vessel sizes, and very different histologic patterns. This is one of the slides where pathology, histology, and real-world urgency collide. Temporal arteritis, also known as giant cell arteritis, is a localized autoimmune vasculitis that primarily affects large and medium-sized arteries, most famously the temporal artery. This is a chronic granulomatous inflammation, meaning it's driven by immune cells that don't just pass through. They set up camp in the vessel wall. This condition is considered a medical emergency because the inflamed artery can become critically narrowed. Reduced blood flow to the eye or brain can result in permanent blindness or stroke. That's why treatment often starts before biopsy results are even finalized. Vision loss from giant cell arteritis is often irreversible, so timing matters. Diagnosis is confirmed by a temporal artery biopsy, which is where you come in. On H&E, classic findings include marked intimal thickening, disruption of fragmentation of the internal elastic lamina, dense lymphocytic infiltrates, and multinucleated giant cells within the vessel wall. The inflammation is often segmental, meaning skip lesions are common. That's why long biopsy samples matter, multiple levels are often required, orientation and section quality are critical. Think of it like sampling a pothole-filled road. If you only look at one spot, you might miss the damage entirely. Treatment typically includes high-dose corticosteroids, often combined with aspirin. Even though steroids may blunt histologic findings over time, biopsy is still essential to confirm the diagnosis, rule out mimics, and justify long-term immunosuppression. Temporal arteritis is autoimmune, vessel size specific, histologically distinctive, and clinically urgent. This is one of those diagnoses where your slide really can save someone's sight. This one looks dramatically clinically, but histologically it's actually pretty quiet, and that contrast is the key. This is the Raynaud syndrome. Raynaud syndrome is a functional vascular disorder, meaning the problem is how blood vessels behave, not what they look like structurally. The hallmark is exaggerated vasoconstriction of small arteries and arterioles, most commonly in the fingers, hands, sometimes toes, ears, or nose. Unlike vasculitis, there is no inflammation destroying the vessel wall. This is a reversible spasm. Attacks are typically triggered by cold exposure, emotional stress, smoking, since nicotine is a powerful vasoconstrictor. Clinically, patients often show the classic color changes. So white for ischemia, blue for deoxygenation, and then red for reperfusion. Fun but useful analogy, think of Raynaud as the blood vessels overreacting, like someone turning the faucet completely off instead of just lowering the flow. And women are affected more often than men, often begins in younger adults, and may exist on its own or as part of something bigger. Primary versus secondary Raynaud. This distinction matters clinically. Primary Raynaud has no underlying disease, is usually milder, and results in no tissue damage. Histologically, is typically unremarkable. Secondary Raynaud occurs in association with autoimmune diseases, is much more concerning, and can lead to ulcers, ischemic injury, or necrosis. Some examples: approximately 80% of patients with systemic sclerosis and 20% of patients with systemic lupus erythematosus have secondary Raynaud syndrome. If you do not see structural vessel changes, inflammation, or fibrosis, you should be thinking secondary Raynaud or an entirely different diagnosis. Primary treatment focuses on avoiding triggers like the cold, stress, or smoking, keeping your extremities warm, vasodilators in more severe cases. That avoid triggers line at the bottom of the slide is doing a lot of work, and it's absolutely accurate. Raynaud syndrome is functional, but functional, not destructive. It's reversible. It's a great contrast to vasculitis, and it's a reminder that not all vascular disease leaves a histologic fingerprint. Sometimes the most dramatic clinical pictures come from vessels that look perfectly normal under the microscope. This is one of those conditions that can be completely silent until it suddenly isn't. Thrombophlebitis refers to formation of thrombi within veins, often accompanied by inflammation of the vessel wall. The most clinically significant form involves the deep veins of the legs, known as deep vein thrombosis or DVT. About 90% of thrombophlebitis cases involve deep veins, and that's why we take this so seriously. The most common risk factor is prolonged immobilization, so long hospital stays, bed rest, long flights or car rides, or post-surgical patients. A simple analogy is the venous blood flow is like traffic. If cars stop moving, accidents happen. So slow flow equals a clot risk. From a pathology standpoint, this ties directly into Virchow's triad: stasis of blood flow, endothelial injury, and hypercoagulability. You don't need all three, just one can be enough. One of the most frightening aspects of DVT is that it can arise silently, grow up to 2 feet long, and cause no obvious signs or symptoms. There's no pain, no redness, and no swelling, just a clot quietly forming. The real danger occurs when part of the thrombus breaks loose, travels through the venous system, it lodges in the lungs as a pulmonary embolism. Consequences of that include pulmonary infarcts, severe respiratory compromise, and if the clot is large enough, instantaneous death due to complete occlusion of the pulmonary artery. This is why DVT is often described as a medical time bomb. If you were to look microscopically, laminated thrombus, or lines of Zahn in some cases, that's what we'd see. We'd also see fibrin, platelets, trapped red blood cells, and possible inflammatory response in the vessel wall. Over time, older thrombi may show organization, fibroblast ingrowth, and partial recanalization. Management focuses on preventing growth and embolization, so anticoagulants are a mainstay. Thrombolytic drugs in select cases are used, and then surgical intervention when necessary, such as a vein ligation or a thrombectomy, which is removal of the thrombus. From a prevention standpoint, early ambulation, compression devices, and prophylactic anticoagulation in high-risk patients is helpful. A big picture takeaway is thrombophlebitis is common, is often silent, can be rapidly fatal, and is preventable in many cases. This is a disease where what you don't see can absolutely kill the patient. This is what happens when veins lose their ability to do their one job well: get blood back to the heart. Varicose veins are dilated, elongated, and tortuous veins that result from chronic venous insufficiency. I call them very close veins because you can see them in the leg. So, unlike arteries, veins operate under low pressure. They rely heavily on valves and skeletal muscle contraction and are much more vulnerable to failure over time. When venous valves fail, blood pools instead of moving forward, stretching the vein wall and worsening the problem. Think of venous valves like one-way doors. Once they break, blood keeps drifting backward and piling up. In the hallway, the vein stretches to accommodate it. Varicose veins can develop in several predictable locations. The anus, which is clinically known as hemorrhoids, is just caused by increased venous pressure, often associated with straining, pregnancy, or prolonged sitting. We can see it in the lower esophagus and the esophageal varices, typically caused by portal hypertension, where we have increased pressure in the portal vein, increased resistance to blood, and then returning to the heart from the intestines. This is commonly associated with chronic liver disease. And these are especially dangerous because rupture can cause massive, life-threatening hemorrhage. And then there's the legs, it's the most common site overall. They frequently involve the greater saphenous vein. Risk factors include prolonged standing, pregnancy, obesity, aging, and of course, family history. Microscopically, varicose veins show thinning of the vessel wall, loss of smooth muscle tone, and stretched, distorted venous valves, as well as irregularly lumen shape. Over time, chronic venous congestion can also lead to edema, skin changes, and venous stasis ulcers, especially near the ankles. While leg varicosities are often considered cosmetic, they can lead to chronic pain and heaviness, swelling, skin breakdown, and increased risk for superficial thrombophlebitis. Esophageal varices, however, are a medical emergency waiting to happen. So big picture takeaway, our varicose veins reflect valve failure, chronic pressure, and progressive venous wall damage. This is a slow mechanical problem, but its consequences can be anything but slow. Okay, so shock doesn't fail one organ at a time. It fails systems in a feedback loop. And this slide illustrates why shock is so dangerous. Once it starts, it feeds itself. So shock leads to inadequate tissue perfusion, meaning cells are not receiving enough oxygen, nutrients, or waste removal. As tissues become hypoxic, cellular metabolism fails, and organs begin to shut down, not independently, but together. Shock is not a straight line, it's a spiral. When perfusion drops, cardiovascular system it affects the cardiovascular system by decreased cardiac output, weakened myocardial contractility, reduced ability to maintain blood pressure. This worsens perfusion everywhere else, including the heart itself. It also affects vasculature, so endothelial injury, loss of vascular tone, increased permeability or leaky vessels. The fluid shifts out of circulation, so it's less effective blood volume, even if total blood volume is normal. This is where you see endothelial swelling, junctional disruption, and later microthrombi. It affects the inflammatory and hemostatic systems, so we would have cytokine release, activation of coagulation pathways, and formation of microthrombi, which are these tiny clots block capillary beds, further reducing oxygen delivery at the microscopic level. It's like traffic accidents happening at every intersection at once. Nothing can move. Then there's the lungs, increased capillary permeability, pulmonary edema, impaired gas exchange. This leads to worsening hypoxia, which accelerates cellular injury across all organs. And then the kidneys, reduced renal perfusion, acute tubular necrosis, decreased urine output. Once the kidneys fail, acid-base balance, electrolytes, and volume regulation collapse. So feeding back into the cardiovascular failure. The GI and liver, the ischemic injury to intestinal mucosa, breakdown of the gut barrier, translocation of bacteria and toxins into circulation. The liver, already hypoxic, cannot detoxify effectively, so fueling systemic inflammation. The CNS and endocrine systems, we'd see altered autonomic regulation, dysregulated stress hormone release, a loss of compensatory mechanisms. At this stage, the body can no longer self-correct. Why this matters clinically is that once multiple organ systems enter this cycle, shock becomes progressive, treatment becomes less effective, and mortality rises sharply. This is why early intervention in shock is critical before the cycle locks into place. Shock kills not because one organ fails, but because they all fail together and help each other do it. And this slide sets the stage for understanding why shock is a medical emergency and why supportive care must target multiple systems at once, as well as why histologic damage often lags behind the clinical collapse. All right, let's shift gears and talk about more about shock, because this is one of those topics where everything you already know about vessels, blood flow, and tissue perfusion suddenly come together. At its core, shock is a failure of the microvascular system to maintain adequate blood pressure and tissue perfusion. So in other words, the heart and vessels can no longer deliver enough blood to meet the metabolic needs of tissues. And when that happens, cells suffer, and they suffer fast. No matter the cause, shock tends to present with a recognizable pattern. So decreased blood pressure, this is the defining feature. Perfusion pressures drops and organs don't get what they need. We might see an increased heart rate. The body tries to compensate by pumping faster, essentially yelling, "Move the blood faster." Decreased urine output. The kidneys are extremely sensitive to perfusion, so low urine output is an early and very important red flag. Altered states of consciousness. When the brain isn't getting enough oxygen or glucose, confusion, restlessness, or loss of consciousness can follow. If the brain and kidneys are struggling, shock is already well underway. Shock isn't one disease, it's a final common pathway with multiple possible starting points. Let's break down the major types. We have cardiogenic shock. This occurs when the heart cannot pump effectively. The problem isn't the vessels or the blood volume, it's the pump itself. So examples include massive myocardial infarction, severe arrhythmias, and end-stage heart failure. Damaged myocardium means fewer functional cardiomyocytes, and no amount of fluid will fix that. We have hemorrhagic shock. Here, the issue is loss of blood volume. This can result from trauma, internal bleeding, and surgical complications. Less blood volume means less preload, less cardio output, and ultimately less perfusion everywhere. Analogy here is you can have a perfectly good pump and pipes, but if the tank is empty, nothing moves. We have septic shock. This one is especially important and often misunderstood. In septic shock, overwhelming infection causes inappropriate dilation of small vessels, pooling of blood in the periphery, leaky capillaries due to endothelial injury, and blood pressure drops even though blood volume may be normal. Histology tie-in here is endothelial activation, cytokine release, and microthrombi formation are major players here. This is where inflammation and shock collide. Then we have neurogenic shock. This occurs when neurologic control of vascular tone is lost. Without sympathetic input, small vessels dilate, blood pools, blood pressure drops, and this is commonly seen with spinal cord injury and severe central nervous system trauma. Unlike other forms of shock, heart rate may not increase because autonomic signaling is impaired. Hypertension without tachycardia should make you think neurogenic shock. And from your perspective at the bench, shock explains multi-organ ischemic injury. It underlies findings like acute tubular necrosis, centrilobular hepatic necrosis, and hypoxic brain injury. It also explains why tissue damage may appear diffuse and nonspecific. If perfusion fails globally, pathology doesn't stay localized. And shock isn't just low blood pressure, it's failed tissue perfusion. Different causes, same dangerous endpoint. The cells switch to anaerobic metabolism, ATP production drops, organs fail, and histologic damage follows. This slide sets us up perfectly to understand why shock progresses so rapidly and why early intervention is critical, because those vicious cycles you just saw become irreversible. Now let's talk about what happens when shock doesn't stop. When shock persists, the body doesn't just struggle in one place, it starts to fail system by system. This is what we mean by multiple organ system failure. and one of the most important and deadly manifestations is acute respiratory distress syndrome, or ARDS, ARDS. The lungs are especially vulnerable because they sit at the crossroads of the circulatory system and the immune/inflammatory response. In ARDS, the primary injury occurs at the alveolar capillary interface, one of the thinnest and most delicate barriers in the body. And from a histology perspective, thin structures are great for gas exchange, but terrible when inflammation gets involved. Let's break down this layer by layer. Epithelial cells lining the alveoli become damaged. This includes type 1 pneumocytes, which are responsible for gas exchange, type 2 pneumocytes, which are responsible for surfactant production. Once these cells are injured, gas exchange becomes inefficient, surfactant production drops, and alveoli begin to collapse. Loss of type 2 pneumocytes equals loss of surfactant, so it becomes stiff, non-compliant lungs. As endothelial and epithelial barriers break down, the plasma leaks into the alveolar spaces, lungs fill with protein-rich edema fluid, and red blood cells may leak in as well. This is not heart failure edema. This is leaky capillary edema driven by inflammation. On slides, this translates to pink eosinophilic fluid in alveoli, cellular debris, and formation of hyaline membranes. If you see hyaline membranes, you should immediately think ARDS. Why breathing becomes so difficult is because at this point, oxygen cannot efficiently cross the alveolar wall. Ventilation may be present, but perfusion and exchange are not. Patients become profoundly hypoxic, even with oxygen support. This is why ARDS patients often require mechanical ventilation, high levels of oxygen, and intensive care support. And even then, outcomes can be poor. So how this fits into multiple organ failure is that the lungs often fail first, but they are not the only victims. Persistent hypoxia and inflammatory mediators lead to kidney failure and acute tubular necrosis, liver dysfunction, cardiac strain, brain injury. At this stage, the body is caught in a self-reinforcing loop of inflammation, hypoxia, cellular injury, and organ failure. ARDS is not just a lung disease, it's a manifestation of system failure. From a histotechnologist standpoint, ARDS explains why lung sections may look flooded and chaotic, why alveolar architecture is distorted, why multiple organs often show ischemic or inflammatory injury at the same time. This slide is the bridge between vascular pathology, shock, and why patients deteriorate so quickly once compensation fails. Okay, this slide is where things get especially dangerous because DIC is one of those conditions that sounds contradictory, and honestly it is. Disseminated intravascular coagulation, or DIC, is essentially the body trying to clot everywhere at once, and in doing so, completely losing control of hemostasis. At the center of DIC is endothelial injury. Remember, endothelial cells normally prevent inappropriate clotting, regulate platelet activity, and keep blood flowing smoothly. When they're damaged by sepsis, shock, trauma, malignancy, or obstetric complications, they flip from being anticoagulant to procoagulant. Think of endothelium as traffic control. In DIC, every light turns green at the same time. Once the clotting cascade is systemically activated, thrombin generation goes into overdrive. Fibrin is deposited inside blood vessels, not where it belongs. This is not a localized clot. This is intravascular fibrin deposition throughout the body. Two catastrophic things happen at the same time. And this is the key concept that you as students need to get. Microthrombosis, these are fibrin that forms tiny clots or microthrombi in the capillaries and the small and mid-sized vessels. These clots obstruct blood flow, so organs become ischemic and begin to fail. You may see fibrin strands within capillaries, especially in kidneys, lungs, brain, and liver. This leads directly to organ failure. The second is bleeding at the same time. While the body is forming clots everywhere, platelets are consumed, coagulation factors are depleted, so paradoxically, the patient is clotting internally and bleeding externally. This is why DIC patients may have petechiae, ecchymosis, and bleeding from IV sites or mucosal hemorrhage. The body has essentially used up all its clotting supplies. The flowchart on this slide captures the brutal logic of DIC. System coagulation results in microthrombi, which results in organ failure. Platelet and factor depletion results in bleeding. Together, these processes rapidly spiral towards death. Once DIC is fully established, treatment becomes extremely difficult, and the goal is often damage control rather than reversal. DIC is not just a coagulation disorder, it's a manifestation of systemic collapse. From a histotechnologist's perspective, DIC explains why multiple organs may show ischemic injury, why fibrin may be present in places it absolutely shouldn't be, and why slides from DIC patients can look chaotic, inconsistent, and severe across tissues. This slide ties together endothelial dysfunction, shock, inflammation, coagulation, and multi-organ failure into one final catastrophic endpoint. And this slide is your reminder and mine that pathology is complex and it's completely normal to walk away with questions. If your brain feels a little full right now, that's expected. We just covered vascular regulation, hypertension and its complications, autoimmune and inflammatory vascular diseases, shock, etc. That's a lot of physiology, pathology, and histology layered together. If something didn't click, you're not behind, you didn't miss something obvious, and you're definitely not alone. Histopathology is learned iteratively. Concepts make more sense once you see them repeatedly on slides, in cases, and in different organs. Think of this like learning to recognize tissue patterns. The first time, everything looks pink and purple. The second time, shapes start to stand out. The third time, pathology jumps out at you. Understanding vascular disease works the same way. So focus on patterns and mechanisms, not just visuals. From a histology standpoint, always remember section orientation, staining quality, fixation, and processing artifacts can all influence what you think you're seeing. Please reach out if you have questions about this lecture, about a specific disease, about histologic features, or about how this material connects to the lecture. Email me or come to office hours. Pathology isn't meant to be learned in isolation. It's collaborative by nature. And one final thought. If you remember nothing else from this unit, remember this. Vascular pathology almost always starts with dysfunction of normal structure and regulation, especially the endothelium. Once you understand normal, the disease processes start to tell a logical story. And we'll keep building on that story together.